Hi, my name is Debbie, and I am obsessed with all things to do with ultrasound. I'm an empty nester who has spent the last 28 years scanning in all different kinds of situations: clinics, hospitals, point of service, emergency departments, private offices, echo, vascular, general, high-risk OB, and want to dive down deep into all things to do with technology, techniques, and transformation. It's time we take ultrasound to the next level. Think of this like your little power boost on your commute to all things ultrasound, along your way to the thing that we call work. So pull up a seat, make sure you're comfy, and be ready to be challenged and encouraged as we learn it's all about the frequency. Today, our guest is Desiree Luna. She has graduated from X-ray school in 2002. She then went on to complete her ultrasound training in 2009. She continued to grow her life into a bachelor's degree, a bachelor's in science degree in 2013. She used that degree to teach ultrasound for a little while, but she missed patient care. So she went back to that, and she does primarily vascular ultrasound. She's done vascular ultrasound for the last 8 years and found that to be her passion. She lives with her 4 children in San Antonio, Texas, with her husband and 2 of her youngest children. Today, our topic is pathology, vascular pathology, and she will just review with us different pathology that she runs across often in her vascular practice. Please help me welcome Desiree Luna. Desiree, thank you so much for joining us today on the podcast to talk about pathology of general anatomy. And I am so grateful that you're here to talk about these topics because they're not things that we see every day.
Right. Thanks for having me.
You're welcome. First of all, just tell us a little bit about yourself and why you got into ultrasound. Let's start there.
Okay. Let's see. My first job in healthcare was in high school, actually, and I worked at a nursing home assisting CNAs, who are amazing, by the way. I don't think they get enough credit.
Yes.
And that started my journey into healthcare. I graduated from X-ray school in 2002 and did X-ray for a while in pediatrics. And then I went on to ultrasound school, graduated from that in 2009. I've been doing ultrasound ever since. There was a little while where I did X-ray, CAT scan, and ultrasound. But keeping up with all the different CEs and all the different requirements, I was like, just do ultrasound. Finished my bachelor's and then went on to teach for a little bit. Missed patient care. So I came back and have been doing vascular since 2017, just strictly vascular. I do some general still, but mainly vascular is my jam.
Awesome. Awesome. I love it. We need people like you because I cannot stand vascular.
It's one of those, you either love it or you hate it. And I love
Right.
it.
And that's same with OB, right? So you
Yes,
love it.
exactly.
And I love the concepts of, I love to see that this is how our body works, right? I think in
Oh, yeah.
vascular, it really brought an understanding to the connections of everything and how everything breaks down and gets absorbed in our body and,
Hmm.
you know, different things. So vascular kind of put things together for me when I studied it, but I certainly didn't enjoy it. So,
I didn't enjoy it when I was first learning it, but I think it's because I didn't fully understand it. And then once it finally clicked, I love those aha moments.
yeah,
Then yeah, I fell in love with it after that.
that's awesome. That's awesome. I try to work to stay out of your department personally.
And I try to work to stay out of yours.
That's amazing. Wonderful. So let's start with the topic of carotids. You had some pathology.
So I know in the general setting, we would do carotids also, but in vascular, the majority, I would say a good 98% of our patients have some kind of calcifications. Usually it's just, oh, it's routine surveillance to make sure it doesn't get worse. But sometimes we have those instances where internal carotid is completely occluded or a common carotid is completely occluded. I had a patient like that. Internal carotid was occluded on one side, common carotid was occluded on the other side, and she was fairly young. I would say maybe mid to late 30s to
Oh,
have that kind of pathology, but she had other autoimmune stuff going on that unfortunately caused that.
okay.
But our body's amazing and we find different ways to get blood where it needs to be. So you got the circle of Willis in your brain, and that kind of helps shut that around. But most of the patients that I have some kind of calcifications and some minimal stenosis. But sometimes you get the stenosis that's like an 80 to 99% stenosis where peak systolic velocity is above 200.
Oh,
I've got it as high as like 800.
wow.
So the ratio is really crazy. So they'll either go in to do an endarterectomy or they'll go in and do a TCAR, which is they just go and put a stent up in that side. The vascular surgeon that I work with, and this is crazy to me, but at the same time, really smart. He actually has patients awake when he does the endarterectomies so that they can talk to him to make sure that they don't throw off like an emboli and cause a stroke.
Oh, wow.
Yeah, I had a patient tell me, yeah, I was just sitting there talking to him for like half an hour. I was just like, oh my gosh.
That's amazing.
And sometimes we'll get carotid dissections. That doesn't happen super often. I think that probably that's an emergency situation where they'll go to the ER, they'll do a CT angio, and then they'll see it. So I don't usually see those types of patients. Um, I'll have patients that are post-op endarterectomy and we'll check to make sure that everything's cleaned out and there's no like swelling that will cause stenosis or anything like that. Usually they're pretty good. And then vertebrals, sometimes you'll get them retrograde, which is a subclavian issue. I'll have those sometimes too. And usually I already know that because I'll do an ABI a lot of times on those patients as well. And the brachial pressures are really different.
Okay. Yeah. So, understanding their history, getting their history
Yeah.
sometimes, really is important, right?
Oh
Just,
yeah. And sometimes I think they'll probably be annoyed with me, like, didn't you read my chart? And I always let them know I was looking over your chart, so tell me what's going on because I saw this, this, and this. Um, and sometimes they forget to tell the doctor something, or they tell the doctor something that they don't tell me, so I already know what's going on.
yeah. So getting that history can either tell you what's most likely going on, but yeah,
Mhm.
allow them not to miss any
Yeah, exactly.
history, right? Oh yeah, I forgot to have this surgery or, oh,
Uh,
I had this removed and
I,
I'm still
I
looking
work
for it,
in
right?
freestanding ER. Yeah, I work in freestanding ERs on Monday and Tuesday, just taking call to keep my general skills up. And I've had actually at least 2 or 3 patients in the last year who have had a cholecystectomy, and I come in to do a gallbladder ultrasound. And so I'll verify with the provider. I'm like, okay, they said they don't have a gallbladder. Oh, they didn't tell me that. Okay, well, they told me, and I can see the scars on the belly. So what do you want me to do? Sometimes they still want me to do it just to make sure that they don't have any stones in the ducts or anything like that. But usually I don't have to.
That's funny. So tell me a little bit about the circle of Willis and how it compromises. For earlier, you mentioned that there was a block in the carotid and
Mhm.
the internal. So tell me how that shunts blood away and
Well,
compromise.
essentially, it's like your body's own collateral pathways. So, a lot of times when you're on the freeway and there is a wreck, that could be like an occlusion or a stenosis.
Mhm.
And what do? You get off on the feeder road, right?
Right.
Um, that's basically what our body does with blood flow. If one area is blocked, it finds another area, another way to get there, essentially. There's different variations of the circle of Willis. Usually, some people are missing some little branches or something. It's just genetic anomalies that we are all born with. But most of the time you have your vertebrals to act as collaterals. You have your external carotid, which will actually have retrograde flow sometimes if it has, like if the common carotid is occluded, then the ECA will just kind of whoop, shut blood around there into the internal carotid. I don't usually visualize the circle of Willis, but I'm familiar with how it works as far as collateral pathways go.
Okay. Right. Because in my field, we do visualize the circle of Willis. So, right, in high risk OB. So
And the
interesting.
cerebral arteries.
Yeah. Yeah. Interesting how we cross
Mm-hmm.
a little bit that way. So tell me about some pathology with the aorta.
Well, usually when you think aorta, you think aneurysm, right?
Right.
I actually do see quite a few aneurysms, or it's not quite aneurysmal yet. It has to be 1.5 times as far as measurement goes, the adjacent area. Sometimes it's not quite that, so we call it ectasia, but they still follow it. I had a patient come in because they had a pulsatile mass on their belly during a routine physical exam. Come in and the aneurysm is 7 centimeters and extremely pulsatile. And that's one of those instances where I'm afraid to push on the belly. I don't want this thing to explode. So usually the vascular surgeon will take them in and do an EVAR, which is an endoscopic vascular approach for essentially correcting the aneurysm. So they'll have like this little stent graft. And it's funny when you see them not in a patient, just like their visual aids that they use to explain things, they look like a pair of pants. Unless it interferes with the renal arteries and it has like little branches of the stent that'll go into the renal arteries as well. What they do is they come back and make sure that there's no blood flow in that residual sac after they've had this repair done. And usually you can see thrombus and stuff in there, and we measure the sac size to make sure it's not getting bigger or anything like that.
Awesome. What about, you had mentioned, well, you had mentioned renals. So do you have any anatomy that you, well, I guess you visualize renal arteries then if you're.
I do, yeah.
Yeah.
It's one of the harder ones to do because it's hidden behind everything. So for renal arteries, we look for stenosis, which could be a cause for high blood pressure on a patient that they don't have any other reason for it to be high. Or they have fibromuscular dysplasia, which is like a string of pearls. It affects the renal arteries and it also can affect the internal carotid artery. I've had a few patients with that. And a lot of times the doctor will put in a stent to kind of correct that stenosis in the renal arteries and kind of help the patient's blood pressure come back down to normal. I recently had a patient who one of her renal arteries was actually occluded from high blood pressure that was uncontrolled, and her kidney died. It was really difficult to see. I could see her little kidney, but there was no blood flow there.
Real nice and bright for you, right?
Yeah. It kind of blends in with all the other grays.
So do you know approximately the size of a renal artery?
No, not off the top of my head, but I could tell you sometimes if they think things are aneurysmal, like they've had a CT or something like that, and they think there's an aneurysm, it's usually over a centimeter.
Okay. Yeah, because I remember doing them, renal artery Dopplers, and thinking, oh my God, this is
They're
like
tiny.
trying to find a piece of hair or something, you
Yeah,
know?
exactly.
They're not easy to find and they're not easy to image or visualize. And angles, I think,
No.
are super important when it comes.
Absolutely.
Do you have any tricks or trades to try to find them?
Usually what I do is I always start with the aorta because you have to have that reference so you can get your resistive index. And then I'll stay transverse on the aorta. And sometimes you can see, I would say about 3 times out of 10, you can see where it comes off of the aorta. That's a good angle usually for you to get the proximal artery as well as the origin. But typically what I do is I'll roll them on the side and I'll just do a side approach and use my kidney basically as a window, because when you're at the renal pelvis, that's obviously the distal end of the artery.
Right,
And
right.
so I just walk it down from there and kind of decide where my mid is going to be.
Yeah.
And that's usually a fairly good angle that you can get.
So tell me a little bit about SMA cancer. You had mentioned that you had a case with that. Is that correct?
Um, no, basically what I have is there's stenosis in the SMA.
Oh, okay.
So basically what happens is patients present with pain after eating. It's severe pain, so much so that they don't even want to eat. So they'll lose a lot of weight, unfortunately, because of that. And of course, ultrasound, everything gets ruled out. Gallbladder, they do an endoscopy, make sure their stomach's okay, and then they go and they have us do an ultrasound and see if there's a stenosis. While they're fasting, if we do not find a significant stenosis, meaning greater than 200 centimeters per second, then we'll have them drink like an Ensure or some kind of meal replacement shake, and then scan them again in 30 minutes. And if they do have a stenosis that didn't show up preprandial, it will definitely show up postprandial. We'll
Okay.
get a really significant velocity in that. I've had them in the 800s. It's amazing. I can get my probe at an angle where I can get that good of a velocity, I guess.
Yeah.
But that's usually
Yeah.
what happens. Then you check the celiac access. Sometimes patients have a stenosis there that can cause pain. And you also check the splenic artery and hepatic arteries. And then you go further down. And if they have a stenosis in their SMA, a lot of times their inferior mesenteric artery is going to be dilated. So you'll see that a lot better too. But we check that as well.
So tell us a little bit about fistulas and grafts.
I love those. I think they're some of the easiest things to scan. So fistulas, a lot of times what happens is we'll have patients come in. If our vascular surgeon didn't place the fistula, they would usually come in because dialysis is having issues accessing it. So what they want to check is to see if it's too deep. If it's greater than half a centimeter in depth, then that's considered too deep. And then they'll have to have surgery to kind of move it a little bit closer to the surface so it's easier to access. Sometimes they're not getting good return because there is a stenosis in there. So you image the inflow artery, the anastomosis for the fistula, prox, mid of the fistula, and then cephalic, because there's not a distal anastomosis. It just goes straight into the central venous system, usually with the cephalic or basilic artery. So you're going to be looking at the subclavian vein. It's going to be the cephalic or basilic vein that goes into the subclavian vein. So a lot of times you might see patients that have a lot of, looks like varicose veins on their chest and up their neck. Usually that happens because they have some kind of central venous stenosis or even occlusion from prolonged dialysis.
Yeah, and those fistulas don't last long, right?
Um, they can last, 8 years. I actually did have a patient who had one for 20 years. There was lots of calcifications in there. There's lots of little aneurysms on it. But if you take care of it and you have a place that knows how to access it properly, then they can last a while, which is good because it's better to be able to use your own parts versus a cow vein or a cadaver vein. So there are techs at the dialysis centers who access it, and they go by the field because there's a thrill as far as the dialysis access goes. I kind of think it's similar to if you had like a bee or a fly in like a plastic bag, that buzzing, that's how it feels. And if it's more of a thump, then usually there's an occlusion. And a lot of times, if you have a good experienced tech, they'll be able to tell that. They'll be like, okay, I don't think you can do your dialysis today. I think you need to go get your fistula checked out or your graft checked out. That's when we would see them. And sure enough, they would have some kind of a stenosis or Sometimes they clot off. That happens too. Or they push the needle too far through and then extravasates all that fluid back into their arm, and they have like a Hulk looking arm and like a normal arm on the other side.
Yeah. And grafts, the same way,
Mhm.
or not so much?
But they actually, usually where I would see the stenosis and grafts is the distal anastomosis, where they would tie it into the vein, and it's usually the axillary vein. And they look essentially the same, especially if they use a bovine graft. It's a cow vein. So they have valves in them. And sometimes it's really difficult to tell, is this a fistula or is it a graft? Until you get all the way down and you can see where it ties into the vein. And then you're like, okay, this is a graft. Or I'll go read the op report to see
Right.
exactly what they put in.
Okay. But you're doing basically the same kind of exam
Yep,
then.
exactly. The only thing is you don't measure the size of the graft or the depth because they know the size and they know how deep they put it. Whereas the fistula, you have to measure the size because it has to be above a certain size before they can start using it for access.
Okay.
They call it mature. It has to mature.
Right. Yeah. Those are so fistulas last longer than grafts typically.
Yes, because it's part of your body, and you're giving your patient who needs a kidney transplant an extended window, so to speak, for them to be able to get that and extending their life.
Right. Right. That's awesome.
Yeah.
So talk to us about thoracic outlet.
So we would see some of those. A lot of times they go to cardiothoracic surgeon for that. But we would put PPGs on the fingers and we would check all of the fingers. And there's different positions that you would place arms or head in to see if you see a drop in the arterial flow of whatever finger you have that on. And that would be a positive for thoracic outlet syndrome. Sometimes we would have ladies come in who have a thrombus in their axillary vein. They don't, they've never had any issues before. They're usually young, I'd say late 20s, early 30s. And all of a sudden their arm swells up. So they go and they're like, oh no, you have a blood clot. Well, usually it's because that first rib compresses everything, not only the nerve, but the veins and the artery. And so they usually have a chronic thrombus in their subclavian vein that moves to their axillary vein and even their basilic or their brachial veins. And what they'll do is a cardiothoracic surgeon will just resect that first rib, and that kind of alleviates all the problems. And usually it's just a incision under their armpit,
Yeah.
but it's a booger to heal from what I understand from the patients I've had with that.
Yeah. Because of the where it's at. Yeah. With
Mhm.
I would imagine. Yeah, my only experience with thoracic outlet was with a young guy who lifted weights.
Yeah, that's very common in the fitness world because these muscles get so big right here that it compresses everything. And a lot of times, if you see the bodybuilders that have the varicose veins across their chest, that's usually what happened. They have like a chronic thrombus in their axillary or their subclavian, and your body finds its own way to get blood where it needs to go.
Yeah.
Ready? Are you a doctor? Okay. I see your caterpillar. Good job. She has dress up clothes in her room. So that's why I was like, go to get dressed.
So let's talk about lower arterioles.
Okay. No, we're gonna go to Lily's house for dinner. Okay.
So I think you and I have probably done enough of these lower arterioles. They like them over even venuses, it feels like, because they go so quick, right?
Yes.
But
Yes.
what's some of the pathology that you run into when you see them?
So a lot of times patients will come in if they're not already established. Sometimes we have patients that are established who had a wound on their toe or that won't heal. or all of a sudden their foot hurts so bad they can't even stand to walk on it. So we will go and I'll do an ultrasound on the arteries to see if there's an occlusion or if there's a significant stenosis that would be causing them breast pain and potentially have wounds. I had a patient where he was monophasic, basically popliteal down, and he had a wound on his toe. And had he not come in to see us, then he probably would have ended up with an amputation because it was that significant. That wound was not going to heal because you weren't getting enough blood flow down there. So that's typically what the vascular surgeons I've ever worked with strive to do, is what they call limb salvage, to try to get that blood flow to go back down there. So I'll see stents because they can open up an occlusion and put a stent to keep it open, same thing that you have in your heart. Or they will do a bypass and go around the stenosis. Sometimes we'll have patients with popliteal artery aneurysms, and if they get large enough, sometimes they'll just occlude because the blood just kind of swirls in there, and they'll do a bypass around that as well. I've seen them go from the axillary to the common fem, and then from the common fem down to the pop, and then common fem to common fem also. They could just like shunt blood flow wherever they want to.
Which is amazing, right?
It is. And it not fun for the patient, but it's very interesting to scan. Did you go tell the puppy to list?
Okay. So let's talk about our last topic of lower veins.
Okay. Everybody hears about varicose veins, right? So many people, especially in healthcare, have varicose veins, myself included. A lot of that has to do with genetics as well. I didn't start wearing compression socks until I started working in vascular and really seeing the importance of them. I love you too. And I wear them every day. I'm at work. Doesn't matter. And I notice a big difference. My feet don't hurt at the end of the day. Of course, you don't have that little bit of swelling that you do in your ankles. You don't have any of that. And my varicose veins have not got worse. Okay. So typically what I'll do is on a patient for venous insufficiency, I check the valve competency of their deep veins, because if it's insufficiency there, there's not a whole lot you can do. You can't go ablate a deep vein. You just have to wear compression. And I also check the valve competency in the great saphenous and small saphenous and any little varicosities that come off of that to see if it's something that the doctor can treat, because if left untreated, you can develop wounds that will not heal. And you have to do compression therapy to try to get those to heal. So the doctor will just go in with a little radio frequency ablation, and it's a little, what do I want to say? A little catheter that goes all the way up the great saphenous, and then it gets hot. So it burns it from the inside so that it'll collapse down, and those issues will subside. They may not decrease completely, but you should get a lot of relief from your symptoms from that.
And their symptoms are mostly
heaviness, itchy over the veins, pain over the veins, achiness, especially towards the end of the day if you're on your feet a lot, which in healthcare, anybody I feel like that's on their feet, their legs are gonna ache at the end of the day.
Yeah. Yeah. Good shoes
too. Anybody that's on their feet all day, their feet are going to hurt at the end of the day.
Yeah. Yeah. I probably need to start wearing those a few times more. Right?
They're a pain to get on and off. I got my husband some too, because he's a realtor and he goes door knocking and stuff sometimes. And it took him a good 5 minutes to get them on. My mom's in healthcare also. I got her some, and she actually does wear them, and she notices a difference when she's on her feet a lot versus not wearing them and she's on her feet a lot. Another issue that people can have is May-Thurner. That's a compression of the left iliac vein. And usually what they present to the ER with limb swelling and pain, and lo and behold, they have a thrombus. And so then they'll come and see us, and that thrombus extends up into the iliac vein. So they'll go and they'll have an angiogram and they'll put a stent in the vein. And then we just monitor the vein to make sure that it doesn't reocclude. I actually have had patients where it does re-occlude, unfortunately, and they'll have to go back in there and do it again. And then blood thinners for a little while and compression, because when you have a thrombus in there, it does disrupt the valve and damages it, so it doesn't work properly anymore. It's essentially like a scar inside of your vein. So you have to wear compression therapy after that. Otherwise, your leg will keep swelling.
Ah, nice. Good to know. So the takeaway is wear compression socks.
Absolutely. Unless you have compromised arterial flow, because then it can like cut off the flow altogether. So then you have to get that checked first.
Yeah. I get more hot, my temperature.
Oh, yeah.
Because it's pushing more blood flow,
Yep.
Up higher. So it's just so interesting, right?
Mhm.
Even just that small thing. Yeah, it takes about 10 minutes to get them on, but yeah.
It does. I always tell patients when they're easy to get on and off, that's when you know you need a new pair.
Yeah. Yeah.
And they're like, oh, okay.
Right. And there's some socks that have different amounts of pressure.
Yes.
Right.
Usually what the doctors would prescribe is 20 to 30 millimeters of mercury. You can go to Walmart or something like that, and they'll have 10 to 15, 10 to 20. And then there's also like some specialty pharmacies where they can actually measure you, because legs aren't all the same size. Some people will require a different size. Usually, they'll have you just go to a specialty pharmacy and then you can get them measured so that they fit you properly.
Perfect. That's awesome.
Mhm.
Well, thank you so much for reviewing all this pathology and anatomy with us, and giving us some good lessons and takeaways of how to take care of ourselves better.
Absolutely. Thank you for having me.
Yeah, you're welcome. And thanks for your contribution to our ultrasound world.
Well,
And for
thank
what
you. I appreciate yours as well.
Thank you for tuning in to It's All About the Frequency podcast. I hope you enjoyed today's episode. Share it with a friend, and remember to keep your frequency high.